continuous cardiac medical education series from UNMICRC Institute of Cardiology and Research Center. Today's my topic of presentation is tricuspid valve, the forgotten valve. Tricuspid valve is the largest and most apically placed valve in the heart. Still, why it is forgotten valve? Because the reason is that the symptoms and signs which are caused by tricuspid valve disease in the early stages it is very uncommon. So when the patient finds their symptoms, the disease is at a late stage. So it is ignored for a long time. So and when we intervene in that condition, the patient will have higher morbidity and mortality. So that is why it is called as a forgotten valve. The pathology regarding the tricuspid valve is tricuspid regurgitation and tricuspid stenosis. The most common is tricuspid regurgitation. There are two causes of the tricuspid regurgitation. One is organic and second is functional, out of which functional is more common. In organic tricuspid regurgitation, there is a pathology within the tricuspid valve apparatus, means tricuspid valve annulus, leaflets, chorda or papillary muscles. And in functional TR, the pathology is in the other, means in the LV dysfunction or due to the aortic stenosis or mitral valve pathologies or any cause due to pulmonary arterial hypertension that leads to the RV remodeling and dilatation of the tricuspid valve annulus that leads to the secondary or functional TR. Now the causes of the organic TR is it can be either prolapse or flared leaflets. It can be due to the endocarditis. It can be congenital, as in the case of Epstein anomaly. It can be iatrogenic due to the pacemaker lead implantation, endomyocardial fibrosis, myxomatous degeneration, traumatic carcinoid syndrome or rheumatic. In functional TR, as we said, it occurs due to LV dysfunction or left-sided valve diseases such as aortic stenosis and mitral stenosis, mitral leak agitation, which leads to increased LA pressure in increased LA size, which in turn leads to the RV dysfunction and tricuspid valve annular dilatation and tricuspid valve leaflet tethering. That is another terminology, isolated tricuspid regurgitation. It occurs in patients with advanced age in which there is no any underlying LV dysfunction or any mitral valve pathology cause, and they are associated with a higher incidence of the atrial fibrillation. This is the etiology of the tricuspid regurgitation, as we have said. Primary, the rheumatic heart disease, tricuspid valve prolapse, flail tricuspid leaflet, endocarditis, papillary muscle dysfunction, connective tissue disorder, carcinoid syndrome and Epstein anomaly. Secondary TR, it can occur due to any causes that lead to LV dysfunction or pulmonary arterial hypertension, and in patients with left to right shunt, ASD, VSD. That's all. Now we see the pathology of the tricuspid regurgitation. There is right ventricular dilatation in left-sided heart valve diseases with pulmonary arterial hypertension, which leads to dilatation of the tricuspid valve annulus. So it fails to shorten during systole. In this case, the leaflets and chorda are normal, and the septal leaflet portion, which is fixed between the right and left trigones and the atrial and the ventricular septum, it lengthens cyst in this process, and there is dilatation of the right ventricular free wall, and the remaining of the 2/3 of the annulus lengthens, means the septal leaflet is fixed and the remaining 2/3, which is the anterior and posterior leaflet, and that is leads to lengthening of the tricuspid valve annulus. This is tricuspid valve annular dilatation, the increased right ventricular and pulmonary arterial hypertension or secondary to the left-sided pathology. Dilatation of the annulus results in failure of leaflet coaptation, and there is a strong correlation between the tricuspid annular diameter and the severity of the TR. As there is dilatation of the tricuspid wall annulus, it assumes more circular shape in a flat plane, and the threshold for TR based on annular dilatation is 27 mm² or 34 mm in average adult. And the degree of the tricuspid regurgitation is influenced by right ventricular preload, afterload, and systolic function. Because the tricuspid annulus is very dynamic with 15% to 20% reduction in circumference during atrial systole. The another pathology is tricuspid stenosis. The most common cause of which is rheumatic heart disease, although it is involved after mitral valve and aortic valve. Congenital tricuspid atresia, carcinoid syndrome, right atrial myxoma, which leads to obstruction of the tricuspid valve, vegetation obstructing right ventricular inflow, and pericardial constriction at AV groove. Now we see sign and symptoms of the tricuspid valve disease. First we will see sign and symptoms of tricuspid stenosis. The symptoms are patient having symptoms of the right ventricular failure, fatigue at rest, fainting, swollen feet and ankles, chest pain, shortness of breath, fluttering sensation, palpitation, arrhythmia, and a heart attack. Palpitation and arrhythmia occurs due to RA dilatation, and there is atrial fibrillation in patients of tricuspid pathology. Sign and symptoms of tricuspid regurgitation: progressive fatigue and weakness, reduction in cardiac output, there is a increased RA pressure which are transmitted through the AVC, and there is a development of the ascites, pedal edema, and hepatosplenomegaly. Symptomatic state of right heart failure and volume overload can be palliated with aggressive diuretic therapy. So generally, when the tricuspid regurgitation is diagnosed, the patient is at initial stage kept on the diuretic therapy, and only when there is very much severe condition which is not controlled by medical therapy, we will interfere with the surgical intervention. Chronic stages, symptoms become refractory, and in late stages patient develop cachexia and jaundice. And tricuspid valve endocarditis in drug addicts. The most common etiological organism is Pseudomonas aeruginosa, followed by Staphylococcus aureus. The valve is rapidly involved and destroyed in the infective endocarditis. The patient develops signs and symptoms of severe tricuspid regurgitation, and the duration of the illness is 1 to 3 weeks. Patient may also have symptoms of pulmonary embolus, and there is a history of the drug abuse, IV drug abuser, and evidence of the pulmonary infection, elevated jugular venous pressure, pulsatile neck veins, pulsatile liver, and a patient may have positive blood cultures. Carcinoid tricuspid valve disease, it is also the cause of the tricuspid valve disease. Patient may have symptoms of the bronchospasm, diarrhea, nausea, malabsorption, flushing, and telangiectasia. There is cicatricial deformity of the tricuspid and pulmonary valves, and tricuspid commissures are fused, chorda tendina is thickened and fused, and leaflets thicken and shorten, which leads to combined stenosis and regurgitation both. And the tricuspid regurgitation is the most common cardiac manifestation of the carcinoid syndrome. History and physical signs of the tricuspid valve disease. In jugular venous pulse, there is dominant fuse C and V wave, followed by sharp deep Y descent, as we can see in this image. And there is a murmur at the lower left sternal edge, which is pansystolic and often high pitch and increase on inspiration. However, when there is a severe tricuspid regurgitation after excision of the tricuspid valve, murmur may be absent. And there is a hepatomegaly, enlarged liver, so systolic pulsation. X-ray of the tricuspid valve disease, so bilateral lung fields are clear. RA enlargement and RV enlargement is associated in it. 2D echocardiography. The vena contracta, which is the predictor of the tricuspid regurgitation, when there is a greater than 0.7 centimeter, it indicates a severe tricuspid regurgitation. There is a paradoxical ventricular septal motion. There is a shift of the atrial septum towards the left atrium in isolated TR. In isolated TR, there is no any LV dysfunction or mitral valve pathology. Only tricuspid regurgitation is there. There is shift of the atrial septum towards the left. And there is quantitative assessment of the tricuspid regurgitation by PISA method, proximal isovelocity surface area method. And there is a dilatation of the inferior vena cava and flow reversal in the inferior vena cava and hepatic veins. Diagnostic criteria for severe TR. IVC diameter is more than 2.5 centimeter and RA area is more than 18 centimeter square in the absence of the ASD or pulmonary valvular diseases. Jet area is more than 10 centimeter square and vena contracta with more than 7 mm. A systolic flow reversal in the hepatic veins in the absence of AV dissociation, ventricular pacing or atrial arrhythmias. Intraoperative. A patient's hemodynamic state must be optimized by the anesthesiologist for any form of assessment to have validity. A surgeon's finger. When inserted through the right atrial appendage, we can appreciate a jet of the tricuspid regurgitation. And the severe tricuspid regurgitation correlates with the jet of the greater intensity, greater width, and increased propagation from the valve orifice. If the TR is very severe, there may not be jet with sufficient velocity to be identified in this manner. On TE, the tricuspid annulus dilatation is defined by more than 40 mm or more than 21 mm per meter square of the body surface area and more than 70 mm on direct intraoperative measurement. Now how to treat the tricuspid valve disease. This is the according to the level of evidence and class for the treatment of the. In the level A, there is a multiple population evaluated and the data are derived from the multiple randomized clinical trials or meta-analysis. Level B, the only limited population is evaluated and the data are derived from the single randomized trial or non-randomized studies. In level C, there is very limited population evaluated and only case studies or opinion of experts or standard of care is there. So these are the level A, B and C according to the population involved, and the class of the treatment is in class 1 the patient will be benefited from the surgery, and class 2A the patient will reasonable benefit, and class 2B there will be benefit or a risk may be equal, and in class 3 the risk is more than the benefit. So now we will see the stages of tricuspid regurgitation. There are 4 stages. Stage A patient who are at risk of developing tricuspid regurgitation, progressive tricuspid regurgitation, asymptomatic severe TR and symptomatic severe TR. The first stage is at risk of TR. Patient has not developed TR but they are at risk of developing TR. These include patient having mild rheumatic changes, mild prolapse of the valve, and infective endocarditis with vegetation, early carcinoma deposition, radiation, patient who have intraannular RV pacemaker or placement leads, and post-cardiac transplant. Patient who are at progressive tricuspid regurgitation, and the valve anatomy shows progressive leaflet destruction. There is moderate to severe prolapse of the leaflets and limited chordal rupture, and there is associated annular dilatation and a moderate leaflet tethering. And on echo we can see the central jet area which is less than 5 centimeter square, and a vena contracta width cannot be defined. In a moderate TR the vena contracta is present but it is less than 0.7 centimeter. If it is more than 0.7 it goes into severe TR, and the central jet area is 5 to 10 centimeters square. Patient has not developed symptoms till now. Patient in stage C show asymptomatic severe TR. There is a clear or grossly distorted valve leaflets, and annular dilatation is severe, more than 4 centimeter or 21 mm per meter square, and there is a marked leaflet tethering, and central jet area is more than 10 centimeter square, and vena contracta width is more than 0.7, and patient has still not developed symptoms till this stage. And the fourth stage is symptomatic severe TR, stage D. Patient having symptoms of RV dysfunction such as fatigue, palpitation, dyspnea, abdominal bloating, anorexia, and edema and ascites. Patient having grossly distorted leaflets and severe annular dilatation with leaflet tethering, and the vena contracta with more than 0.7 centimeter, central jet area more than 10 centimeter, and the historic reversal of the hepatic vein flow. Indication of the surgery. The class 1 indication is tricuspid valve surgery is recommended for patients with severe tricuspid regurgitation, means asymptomatic severe TR and symptomatic severe TR. Patients who are undergoing left-sided valve surgery. The level of evidence C. Class 2 indication for surgery is tricuspid valve repair can be beneficial for patients with mild, moderate or greater functional tricuspid regurgitation at time of left-sided valve surgery with either patient having tricuspid valve annular dilatation or there is prior evidence of the right heart failure. The level of evidence B. Class 2A, tricuspid valve surgery can be beneficial for the patients with symptoms due to severe primary tricuspid regurgitation that are unresponsive to medical therapy. Stage D means symptomatic severe tricuspid regurgitation, and the level of evidence is C. In class 2B, tricuspid valve repair may be considered for patients with moderate functional tricuspid regurgitation and pulmonary arterial hypertension at time of the left-sided valve surgery. The level of evidence C. Tricuspid valve surgery may be considered for asymptomatic or minimally symptomatic patient with severe primary TR who are in stage C asymptomatic severe TR and progressive degrees of moderate or greater RV dilatation and systolic dysfunction. Level of evidence C. And a reoperation for isolated tricuspid valve repair or replacement may be considered for persistent symptoms due to severe TR. Patient in symptomatic severe tricuspid regurgitation in patients who have undergone previous left-sided valve surgery and who do not have severe PH or significant RV systolic dysfunction. In level of evidence C. This is a brief summary regarding it. Tricuspid regurgitation. Patient having progressive functional tricuspid regurgitation. Stage B, if it is mild or moderate. If the patient having concurrent left-sided mitral or aortic valve pathology associated with tricuspid annular dilatation, tricuspid valve repair is considered. In patients of asymptomatic severe TR, it is functional due to secondary LV dysfunction or left-sided valve pathology. Tricuspid valve repair can be done, and it is the primary due to progressive RV dysfunction. TV repair is also considered. And the patient in stage D symptomatic severe TR, it either due to primary functional or reoperative. Tricuspid valve repair can be done according to. And now the method of the surgery, tricuspid ring annuloplasty. The anteroseptal tricuspid valve commissure, membranous part of the anteroventricular septum and the coronary sinus orifice, they are identified and mentally visualize the location of the AV node in the bundle of his. Using appropriate sizers, notches at points corresponding to the anteroseptal and posteroseptal commissure at both the ends of the annulus and leaflet, a proper size tricuspid annuloplasty ring is selected. The first stitch of number 20 or 30 is positioned exactly at the midpoint at the septal leaflet annulus, and only 2 further meter stitches are needed for the septal portion of the ring. This is the surgical view of the tricuspid valve. the devigas TV annuloplasty, in which the posterior septal and anterior septal leaflet commissures is identified and the annuloplasty is done in this manner. Intraoperative picture of TV annuloplasty. Bicuspidization of the tricuspid valve by obliteration of the posterior leaflet and placement of the annuloplasty. This is Case TV annuloplasty, in which the posterior leaflet is sutured and the bicuspid valve is made into the bicuspid valve. Another method is augmentation of the anterior leaflet with annuloplasty ring. Here the anterior leaflet of the tricuspid valve is augmented and followed by placement of the annuloplasty ring. Another method of repair of the tricuspid valve is edge to edge repair. Here is quadrangular resection of the anterior leaflet of the valve is done and followed by the repair of the tricuspid valve leaflet. Repair of the annulus. It is done by narrowing of the annulus only in the lateral half of the anterior leaflet and the base of the posterior leaflet, as we can see in this image. This is the repair of the tricuspid valve annulus. So this was the brief information regarding the tricuspid valve, which is known as the forgotten valve in the past, but at present we are doing intervention in the tricuspid valve pathology at earlier stages associated in left-sided heart valve surgeries. So thank you.